Bismillah ar-Rahman ar-Rahim. Our lecture today uh, about dementia regarding the epidemiology, natural history, and etiology. We will start by the definition. Dementia is a memory loss, behavioral problem, personality problem, and decrease in the functioning. Uh, uh, we can use the mnemonic major PD, memory loss, decreased abstract thought, aphasia, apraxia, agnosia, decreased judgment, organicity should be presumed. Also, we should rule out depression and personality disorder. And last, there is declining in the functioning at work and relationships. It's important to note that if there is associated neurological signs, dementia could be vascular origin. If there is no neurological signs, possibly it will be due to degenerative disorder like Alzheimer's disease. DSM-4 criteria for dementia. Development of multiple cognitive deficits, including memory impairment and at least one of the following: aphasia, apraxia, agnosia, executive functioning disturbance. The cognitive deficit must be sufficiently severe to cause impairment in the occupational and social functioning, represent a decline from a previous higher level of function. Diagnosis should not be made if the cognitive deficit occurs exclusively during the course of delirium. Dementia may be not etiologically related to a general medical condition to the persisting effects of the substance abuse, including toxin exposure or a combination of these factors. Aphasia is a language disorder that affects the ability to comprehend or express spoken or written language or both. The term apraxia is defined as inability to correctly perform learned skilled movements with the arms in the absence of weakness, ataxia, seizures, and involuntary movement. Agnosia can be defined as inability to recognize familiar objects, faces, sounds, or words. Here is a functional topography of the cerebral cortex and the various psychological problems that rise from breakdown of a function of particular cortical area, like apraxia, agnosia, and spatial disorientation, aphasia, alexia, agraphia, amnesia, etc. Here is a table of difference between pseudodementia and dementia. We will start by the pseudodementia, which is mainly due to depression. It has a rapid onset, um, um, where the patient's mood is depressed or apathetic. However, the intellectual functions um, are intact. The patient complains, but on neuropsychological testing, the tests are good and there is no impairment. And the patient came by himself and he is anxious if he have something like Alzheimer's disease. On the other hand, dementia have insidious onset, months to years, fluctuating behavior or apathetic or irritable. There is an objective deficit on neuropsychological testing, but the patient tend to minimize or rationalize the error, and the patient doesn't come by himself, but he comes by or referred by his family, who notices the change in the memory or his behavior. Here is another important table to differentiate between dementia and delirium. dementia have insidious onset with a progressive course ranging from months to years. Attention, speech are normal. However, the language, there may be a deficit in the form of aphasia. Learning deficit also may be present in Alzheimer's disease. Cognition may be also affected, like acalculia in Alzheimer's disease, certain variants of Alzheimer's disease. And the awareness is impaired. There is no motor signs, and EEG shows mild diffuse slowing. On the other hand, delirium has a sudden onset with a fluctuating course ranging from hours to days. Attention is fluctuating. Speech is slurred. Language, there may be anomia and dysgraphia. There is encoding deficit on memory testing. Disorganized cognition with impaired awareness, and there may be associated tremors and asterixis, mainly if it's a metabolic cause like hepatic encephalopathy. EEG shows moderate to severe diffuse slowing. Then we will talk about the classification of dementia. There are many types of classification. Let's start by the primary and secondary one. The primary degenerative dementia may be dementia pure or dementia plus. We mean by dementia pure that the neurodegenerative disorder primarily involving the cerebral cortex, like Alzheimer's disease and focal degeneration. Dementia plus, where the neurodegenerative disorders involving additional brain areas such as the basal ganglia or other subcortical structures, like dementia with Lewy bodies, Parkinson's disease, frontotemporal dementia, Parkinson, multisystem atrophy, corticobasal degeneration, progressive supranuclear palsy, Huntington's disease, and some forms of spinocerebellar ataxia, etc. Secondary forms of dementia includes disorders damaging the brain tissue directly, like a vascular insult, infection, demyelination, metabolic disorder, traumatic injury, post-radiation dementia, some brain tumors, and parasitic cyst and brain abscess. Also, disorder changing the intracranial content and distorting the brain structure, like normal pressure hydrocephalus or obstructive hydrocephalus, subdural or intraparenchymal hematoma, primary or metastatic brain tumors, systemic disease or conditions affecting the brain, like metabolic problem, nutritional problem, like hepatic and renal disease, endocrinological disease, toxin exposure, and systemic immune-mediated inflammatory disorders. Another classification of dementia into a cortical dementias and subcortical dementias. The causes of cortical dementias: Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, Creutzfeldt-Jakob disease, and vascular dementia. This entity is characterized by lack of extrapyramidal motor findings and abnormal speech and behavior. However, subcortical dementias includes alcohol-related dementia, vitamin deficiency related thyroid disease, normal pressure hydrocephalus, dementia pugilistica, which is a traumatic dementia, psychiatric disorder, metabolic disorder, Parkinson's disease, AIDS-related dementia, and also vascular dementia. Clinically, subcortical features include slowness of the thinking, apathy, and extrapyramidal motor findings. Also, we will talk about the treatable causes of dementia. And the importance of these causes is the investigations, either radiologically or laboratory, to detect the cause and treat it. So the causes that could be discovered by laboratory investigation includes thyroid disease, B12 deficiency, thiamine deficiency, which is vernix encephalopathy, pellagra, alcohol, and hepatic encephalopathy. Radiological investigation can also detect normal pressure hydrocephalus, subdural hematoma, benign brain tumors, chronic meningitis, abscess, and cysts. We will discuss Alzheimer's disease in details. We will start by the epidemiology. About 80% of the cases of dementia in older patients characterized by memory loss, personality changes, global cognitive deficit, dysfunction or deficit, and functional impairment, socially and at the work level. Visual spatial disorientation or disturbance, which is the early finding, apraxia, language disturbance, personality changes, delusions, hallucinations, may be later in the course of the disease. Alzheimer's disease is the most common cause of dementia in persons aged 65 years. The prevalence increases with the advancing in age. About 4.5 million in US have Alzheimer's disease. Is the fourth leading cause of death in US after cardiovascular disease, cancer, and stroke. 2/3 of the cases are women. Risk factor for Alzheimer's disease include advancing age, apolipoprotein E, epsilon 4 allele in some population, environmental exposure to aluminum, head injury, poor cardiovascular health like diabetes, hypertension, high cholesterol, and strokes, and smoking. Protective factors include intellectual stimulation, regular physical exercise, regular social interaction, Mediterranean diet like fruits and vegetables, low saturated fat, supplementation with vitamin B, omega-3 fatty acid. Vitamin E also could be protective. Some ongoing studies say that statins and NSAIDs may help also. Regarding the neuropathology, we have neuronal death at the end result. However, as we said before, aging and environmental factor, mutation in some genes may lead to increase in the amyloid plaque, beta amyloid formation and deposition, leading to the tau phosphorylation and aggregation, leading to neuronal death. The aggregated amyloid also cause oxidative damage and mitochondrial dysfunction, inflammatory response, and disturbance in the calcium homeostasis that also leads to the neuronal death. ApoE, lipoprotein, epsilon 4, also leads to accumulation of the amyloid and tau phosphorylation and aggregation. Here's an image illustrating the beta amyloid and the problem with cleavage. This is the microtubules and how it's disrupted in case of Alzheimer's disease, leading to the gross pathological picture, cortical shrinkage, enlarged ventricles, and shrinking of the hippocampus. Also, an image showing the pathological features of Alzheimer's disease where there is deposition of neurofibrillary tangles and amyloid plaques. The Alzheimer timeline. Initially, there is early brain changes, then there is subtle decline in thinking, then there is a memory changes and confusion, then inability to do the daily activities like bathing, dressing, eating without help, and at last lost the ability to communicate and recognize the beloved ones. Initial stages, there's memory problems, including forgetfulness for names, repeating the same stories or the same sentences, misplacing their belongings, making lists. Also, they may be fluctuation in the intensity. It's very good for remote events, and recent events may be affected more than the remote ones. There's poor ordinary recent events. Clues and multiple choices are useful. Language and behavioral problems include affection of the speech, which becomes less fluent and lost its spontaneity, difficulty in word finding, self-awareness of impairment may elicit depression. Also may keep working, especially when the patient is protected by understanding staff in his or her office, may have some difficulties in choosing his dress and complex financial tasks, may keep house, pay bills, drive car, participate in social activities. Intermediate stage of Alzheimer's disease, the memory problem became more apparent. There is a regression, difficulties, forgetting faces, inability to use clues or lists, spatial orientation disturbance, inability to store new. Here is a functional topography of the cerebral cortex and the various psychological problems that rise from breakdown of a function of particular cortical area, like apraxia, agnosia, and spatial disorientation, aphasia, alexia, agraphia, amnesia, etc. Final stage includes language and behavior problems, where the speech is incoherent, may be lost, wandering, purposeless movement, crying, agitation, difficulties in moving and feeding, bathing, and continence toward the end stage of the disease, myoclonus rigidity and gait difficulties. At last, he may become bedridden and death due to infections or embolism. Also, this diagram shows the symptom progression in Alzheimer's disease from mild cognitive impairment to mild, moderate, severe, and profound Alzheimer's disease. Exactly the same that we have discussed before. In this slide, we will talk about cascade of events or mechanism in Alzheimer's disease, from normal to mild cognitive impairment to mild or moderate Alzheimer, then moderate to severe Alzheimer. Initially, there is amyloid deposition, then inflammation. Maybe at this stage the patient is asymptomatic. Abnormal phosphorylation of the tau, free radical toxicity, disturbed calcium homeostasis may respond, may be represented clinically by mild cognitive impairment, synaptic loss, cholinergic dysfunction, neuronal loss in the early stages of Alzheimer, in the mild to moderate Alzheimer. Then norepinephrine dysfunction and serotonin dysfunction is present at the moderate to severe Alzheimer. And here we will talk about the treatment. Anti-dementia drugs, which is the cholinesterase inhibitors, like donepezil, rivastigmine, and galantamine, or glutamatergic drugs like memantine, antidepressants, antipsychotics, behavioral technique, memory retaining techniques, and ABC approach. Novel interventions also may be present, like bright light therapy, aromatherapy, and exercise. All these treatments are used to address the Alzheimer symptoms, including the memory affection, the behavioral problem, the depression, and the psychosis. Thank you.